Hi everyone, my name is Maria Murray. I'm 53 years old, married for almost 18 years and have a 14-year-old son. I've been a registered nurse for the last 30 years, working primarily in chronic disease prevention within public health. Never did I think that I'd be dealing with a life-altering disease like PBC. 2 years after gallbladder surgery, I had a FibroScan that indicated I was at stage 1 to 2 with fibrosis. A year after, I progressed to stage 4 with cirrhosis, extreme fatigue, severe ascites, hepatic encephalopathy, and a MELD score between 9 to 12. And so in 2020, I was referred for transplant. The assessment phase began 2 weeks after the referral. I met with the transplant team virtually because of the COVID pandemic. While it felt like forever, I was approved for the deceased liver donor list in just 2 months. I was really scared as my MELD score continued to increase, and while waiting for the call, they suggested I consider a living donor. Family wasn't a match, so I launched a social media campaign, and I was blessed with 6 potential donors. A close friend of mine was evaluated and approved to donate part of her liver, and so I received my new liver August 2021. I'm very grateful for the excellent care we both received from UHN. I now give back by helping to increase awareness of living organ donation and am a patient partner. Today, it's my great pleasure to welcome Dr. Aldo Montano-Loza to talk more about late-stage disease and what's involved in transplant assessment.
So, good afternoon. First of all, thank you for the kind invitation to participate in this great meeting. It's amazing to be with you and hear all these testimonials. This is a unique experience. So in the next 20 to 25 minutes, I will be talking about what is involved in liver transplant and what happened after liver transplant. So these are my disclosures. And this is the agenda for the next minutes. So I will be talking briefly about what will be the indication to refer a patient with primary biliary cholangitis for liver transplant. I will be talking about recurrence of the disease after liver transplantation and how we can try to reduce the risk of recurrent disease. And finally, for those patients who have recurrent disease, how do we need to stratify the risk of the disease progressing in the graft, and what strategies can we do about that? So we have here during this meeting that primary biliary cholangitis actually was the indication number 1 for liver transplant in the mid-80s. And this is because patients with primary biliary cholangitis are great patients, and they were considered a really good group of patients to initiate liver transplant in North America. It's important to mention that now the need for liver transplant has decreased, and now is the indication number 3 in Europe and the indication number 6 in North America, and approximately 10% of the patients listed for liver transplant have primary biliary cholangitis. And this reduction in the need for liver transplant is basically a reflection of the efficacy of ursodeoxycholic acid, also that I think we are doing a better job making diagnosis in an early stage. And in patients who have actually response to ursodeoxycholic acid, then the prognosis is similar to overall population. And nowadays, the requirement for liver transplant in primary biliary cholangitis has decreased approximately 20%. Now, when do we need to consider liver transplant, as has been mentioned before, are in patients who develop cirrhosis, but then also patients who develop decompensation. And what that means is that besides having cirrhosis, patients develop complications, specifically ascites or accumulation of free fluid in the abdominal cavity, hepatic encephalopathy or confusion associated with liver failure, or if the patient has significant worsening in the liver function reflected by a significant increase in the bilirubin levels. Something also important is that this is going to happen mainly in patients that do not have a complete response to ursodeoxycholic acid, and hopefully we can decrease the frequency of these complications with the second-line treatments. If we follow strictly the lab work, we should consider liver transplant when the MELT score, that is a score composed by bilirubin, creatinine, and INR, is more than 15. And I will try to explain why we use this good point value to consider patients for liver transplantation. Finally, another indication is patients who have liver cancer. Liver cancer happens less frequently in patients with primary biliary cholangitis compared to other etiologies of cirrhosis, but it may still happen. And if we detect the liver cancer in an early stage, patients should be candidate for liver transplantation. As Dr. Hin mentioned before, still sometimes we assess patients with refractory pruritus, but hopefully with new medications, this is going to continue to be less needed. And this is a graphic where I would like to explain briefly how we use the MELT system to allocate the liver transplant. As has been mentioned before, in the axis, in the y-axis or the vertical axis, is the probability of a patient dying because of liver failure. And in the x-axis or the horizontal axis is basically the MELT score. So as you can see, the risk of mortality is basically in columns in red and blue, and the risk of waiting start basically increasing when the MELT score more than 15. So that means that the risk of actually going for a transplant, if the MELT is less than 15, is higher because of the surgical risk and the anesthesia risk than just continue having a close follow-up. But when the MELT score is more than 15, that's when definitely there is a benefit for the liver transplant. I will try to make it a little bit more easy to explain in this slide. So these are some examples, like for example, what is the probability of having a liver transplant if a patient is awaiting for a cadaveric donor? As you can see, if the MELT score is 6 to 10, it's really low. It's like 1.6. That's the probability of receiving a liver transplant, so it's really unlikely. However, if the MELT score is between 26 to 30, the probability is like 50%. And this is reflected in the next 3 months. So what we are trying to do with the MELT score is that when the probability of complications and mortality increase, then the likelihood of receiving a liver transplant is way more higher. So in that way, patients who are sicker are going to be the ones receiving the liver transplants. However, I do need to mention, as the case presented as the statement of Maria, sometimes the MELT score do not reflect in an accurate way the risk of mortality in primary biliary cholangitis, and there is work that we need to do there. There has been some studies using the UNOS database, that's the largest cohort of patients transplanted in the United States, that actually show that patients with primary biliary cholangitis may have a slightly higher risk of dying compared to other patients with cirrhosis. The good news is that this imbalance may be corrected pretty soon. Nowadays, actually, in the United States, it seems like there is a move to approve a new version of the MELT score that is named MELT 3.0. And this MELT score is going to include in the score being a female, because definitely it seems like are in disadvantage to receive a liver transplant. And also it's going to include other markers that is going to capture the risk, specifically albumin, in the interaction that's specifically some statistical analysis between bilirubin and sodium in capping the creatinine. So the accuracy for MELT 3.0 seems to be better, and we are presenting a study in the next American meeting where we found that actually this MELT 3.0 is significantly better to predict outcomes in patients with primary biliary cholangitis. Now, what happened once patients go for a liver transplant? And the outcome is relatively good. I think we can do better. We should be doing better in the next years. But as you can see, the survival after a liver transplant after 5 years go approximately from 80% to 90%, and after 10 years can go from 70% to up to 81%. But we do need to mention that primary biliary cholangitis unfortunately can come back after liver transplantation. And this has been reported in a wide range. So this goes from 17 to 46%. And the difference in this range is because liver transplant centers may do different things. So that means sometimes they do protocol biopsies. So after liver transplant, patients have a liver biopsy at 1 year, at 5 years, at 10 years. Or in other centers, we only send patients for liver biopsies if there is abnormal liver function test after the liver transplant. However, we do know that the frequency of recurrence increase as times go by and could be more than 30% after 10 years. The diagnosis has to be made with a liver biopsy because patients who have a transplant, they may continue being positive for antimitochondrial antibodies. Also, they may continue having an elevation of the immunoglobulin M without meaning that they have recurrence of the PBC. So if we suspect that they have recurrence, then it's indicated to do a liver biopsy. Also because there may be another potential explanations of abnormal liver function tests after liver transplant. That's why liver biopsy is definitely necessary to make diagnosis. And what we do in the liver biopsy, sorry this is a little bit busy, is we basically look for the classical features of PBC before transplant. So this damage of the small bile ducts with infiltration but immune cells that the name of lymphocytes, and also some patients develop granulomas. And we normally say that a patient is going to have recurrent primary biliary cholangitis if they have at least 3 of the 4 portal triads. So we normally, when we do a liver biopsy, it's recommended to have at least 8 areas of this histological analysis, and 3 or 4 has to be affected. Now, this is one study that we did many years ago, and I was really interested to know, so what happened with patients who have recurrent disease? And we found in the cohort of the University of Alberta that 13% of patients have recurrent disease after 5 years and 29% after 10 years. However, something that I was a little bit concerned is that many people used to mention that having recurrent disease, it was not important, that didn't have any clinical significance because the disease was more, it was mild, and it was not going to have any impact in the graft or the patient survival. So because of that, we, in collaboration with the global PBC, we include a significant like a really large number of patients transplanted for primary biliary cholangitis. So we had data from 827, but at the end we exclude 40 patients because there was no clear diagnosis of PBC. So we include 785 patients, and these are patients transplanted in 13 centers in North America and Europe. We analyze those patients who had liver biopsy, either if they had a liver biopsy as protocol or booked in a systematic way, or if they have a liver biopsy because they have elevation of the liver enzymes. And we find that the probability of recurrence in this cohort was similar to what's reported before, so 22% at 5 years and up to 55% after 20 years. Now, what are the risk factors to have a higher risk of recurrent disease after liver transplant? It seems like patients who are younger at the time of the liver transplant. Also, it seems like patients who receive tacrolimus. Having said that, I'm going to mention tacrolimus is still the best immunosuppression after liver transplant, even that definitely it seems like there is an association with recurrent disease. Also, there was a signal for the use of another immunosuppression, that is mycophenolate, and specifically those patients who have cholestasis or elevation of the alkaline phosphatase with and without bilirubin within the first year after the liver transplant. So these are just some graphics, and I'm just going to mention, so patients who had diagnosis of PBC before the age of 50 are marked in the red line, and patients who had diagnosis of PBC after the age of 50 are marked in the blue line. And as you can see, the risk of having recurrent disease is higher in those patients who are diagnosed when they are younger than 50 years. At the same time, patients who are younger than 60 years when they have a liver transplant, they also seem to have a higher risk of having recurrent disease after liver transplantation. So that means that younger age at diagnosis and younger age at liver transplant seems to increase the risk of the recurrence coming back. As I mentioned before, the use of tacrolimus, it seems like it's associated with a higher risk of recurrent disease. But regardless of this, it seems like actually this is the best immunosuppression overall, but it's just something that we need to consider for future studies. But as I was mentioned before, actually these are the most recent guidelines for liver transplantation published by the European Association for the Study of the Liver. And actually there were two statements that we consider this was not reflecting what we see in clinical practice. So the first one was the impact of recurrent PBC on graft function and patient survival is minimal. And the second statement was there is no evidence for prophylactic use of ursodeoxycholic acid in patients transplanted for PBC. So keeping these two statements, we really want to analyze if this was sustained by real data. So in this analysis, we actually evaluate the impact of recurrent PBC in the survival of the graft. And as you can see, patients who have recurrent PBC marked in red, they had a lower graft survival compared to those patients that do not develop recurrent disease. And this was also reflected in overall survival. So the second statement, it was challenged because there was some data specifically from Dr. Christophe Coppershow in France that he put together information from a few centers in France and Switzerland. And he was able to show in a small cohort that actually patients who are starting in preventive ursodeoxycholic acid within the first 2 weeks after the liver transplant seems to have a lower risk of recurrent disease. So working with him, we analyzed the data of patients from the global PBC group, and that include over 900 patients. And then of these patients, 24% were started on ursodeoxycholic acid as a preventive measure. So that means within the first weeks after the liver transplant, they were put back on the ursodeoxycholic acid. And then we have other group of patients, 76%, that they didn't start the ursodeoxycholic acid. So it was evident that patients who actually were started on preventive ursodeoxycholic acid, in this case marked in the line, in the blue light line, they have a significantly lower risk of developing recurrent disease during the follow-up compared to those patients without starting the ursodeoxycholic acid. And more importantly, the use of the ursodeoxycholic acid as a preventive measure was associated with a better graft survival. So the risk of losing the graft was significantly lower in patients who were started on the ursodeoxycholic acid. And this also was this also correlates with a lower risk of mortality related to liver problems after liver transplant, and also all-cause mortality. So keeping that in mind, so nowadays it's recommended that once a patient has a liver transplant because of primary biliary cholangitis, they should be start on ursodeoxycholic acid within the first 2 to 4 weeks after the liver transplant and continue for long term. But what happened once we have a patient with diagnosis of recurrent primary biliary cholangitis? So what can we do about that? And so first, we try to analyze if the current scores that we use in patients before transplant can be used after liver transplant. And it seems like that is the case. Sorry, this is a really busy slide. I'm just including 332 patients who have established histological diagnosis of recurrent primary biliary cholangitis. They were on different immunosuppression regimens. But what we wanted to see is specifically if the scores that we use, like the Toronto score, Globe score, the UK PBC score, and also to see if the alkaline phosphatase or the bilirubin, after 1 year of having ursodeoxycholic acid and diagnosis of recurrent disease, were associated with graft and overall survival, and that was the case. So that means that once we have diagnosis of recurrent PBC, we need to follow the patients, we need to stratify the risk, and we also need to consider second-line treatment in patients with recurrent disease and incomplete response to ursodeoxycholic acid. So this was reflected in the graph, but also overall survival. And as you can see in this graphic, so basically, patients who had the transplant and the alkaline phosphatase is less than 2 times the upper limit of normal after they start ursodeoxycholic acid, in the graphic that you can see at your left, they do really well. But patients who have an alkaline phosphatase more than 2 times the upper limit of normal, despite of ursodeoxycholic acid, the graft survival is decreased. So we need to do something about this persistent elevation of alkaline phosphatase. And the bilirubin is also a marker, but we think that actually this is more a late marker, so we need to act on the alkaline phosphatase. So it was interesting that in this group of 332 patients with a significant proportion of not having complete response to ursodeoxycholic acid, only 74 patients, so 74 patients actually had incomplete response according to Toronto, and only 20 patients were started on a second-line treatment like fibrate, and only 3 patients were started on a second-line treatment with obeticholic acid. So I guess from this experience, definitely after recurrence, we need to continue monitoring patients, and we need to offer second-line treatments in this population. And specifically, this is what we recommend. So after liver transplant, everybody should be on ursodeoxycholic acid, but we need to follow with routine lab work. If there is a concern of recurrent disease, we need to consider a liver biopsy to establish diagnosis. And if there is incomplete response after 1 year or maybe 6 months of treatment with ursodeoxycholic acid, consideration for second-line treatments. The consideration for second-line treatment has to be made carefully because there is interaction of obeticholic acid with immunosuppression, but can be used. And with bezafibrate, there also may be some side effects that needs to be followed during the use of these medications. If, unfortunately, there is recurrent disease and there is decompensation, then the best option is a second liver transplant. But hopefully we will continue decreasing the need of first transplant and second liver transplant in the future. And this is just a study that we are going to start this fall. So this is sponsored by Intercept. So basically we have medication to provide obeticholic acid in patients who have diagnosis of recurrent primary biliary cholangitis and incomplete response to ursodeoxycholic acid. The objective of this study is to monitor the levels of the immunosuppression and obeticholic acid after we started. It's going to be for 12 months, but we will be following this closely. We hope that with this information, if patients develop recurrent primary biliary cholangitis after transplant, we will be able to achieve complete response and prevent progression of the disease after liver transplantation. So I would like to finish this talk just with a few key points. So we need to consider liver transplant in the case of decompensated cirrhosis, so complications secondary to cirrhosis like ascites, hepatic encephalopathy, jaundice, but also in rare cases of liver cancer, but this is a really good option. Liver transplant is a really good option. Everybody who has a liver transplant because of PBC should be started on preventive use of oxycholic acid to decrease the risk of recurrence, and also because this has been associated with better graft and overall survival. If we have diagnosis, histological diagnosis of recurrent PBC after transplant, we do need to use any of the scores to stratify the risk of disease progression and consideration for second-line treatments. I thank you very much for your attention.